There's a news release today on the SCAI report on Transradial Arterial access. So maybe you can tell us about that, and I think you're one of the co-authors of that.
Yep, so this is the first kind of consensus statement that we've had on transradial procedures, and this was from physicians that are in the U.S. as well as outside of the U.S., so a lot of people collaborated to put this paper together. And the paper has a practical aspect to it, which I like, so if you read it, you can kind of just learn how do you do this and why, but it also touches on things that we need to work more on, and so things that we're lacking, data that we're lacking. There's particularly when you read it, you realize, gosh, we don't really have much in terms of guidelines or competency sorts of guidelines of how do you know when you've achieved competency? How do we know when we start training fellows? How do we know what stage they are? So I think that's something that also comes up and is almost a call to people who are putting together competency guidelines and training guidelines to step back and say, have we really addressed this issue? Because if you look at the training guidelines, for example, for fellows right now, the idea of access is very femoral heavy. There's usually a mention of, oh, you should be able to get in the arm as well. And that's really not what a lot of us would advocate right now. We would like people to be equally competent in any sort of access. That seems to be a well-trained interventionalist in my mind. And so maybe having these guidelines that we already have updated so that they reflect that. Of course, to do that, you need to make it so that fellows can get trained, and so we need to make sure that we have training centers where fellows can be trained. We don't want to make guidelines that people can't achieve, but I think that's coming. And then for people who are already in practice, there's this question of competency. And, we proposed in this paper, at least, that we have this tiered sort of level of competency, that you're at a level 1 if you can do a simple sort of diagnostic case with simple arm anatomy, and at level 2 you might have more complex arm anatomy, introduction of PCI, and then by level 3 you would be doing complex PCI with complex arm anatomy, and that you're really then able to do any sort of radial case.
Sounds like that should be excellent reading.
Yeah.
Why do you think it's been so slow for U.S. physicians to catch on to the radial bandwagon?
Yeah, this is always the big question that people can sit and think about. I think some of it is tradition, that, we kind of said, here's how we do it, and we kept doing it. I think there was certainly a struggle in the 1990s, and I wasn't around during the struggle, but if I talked to people who were, a lot of people got really turned off. And maybe we didn't have the right equipment. People certainly used larger equipment during that time that might have made it less easy to do these procedures. We didn't know as much about spasm and how to prevent it. I think now we have smaller equipment that we can use. We have some radial-specific equipment that we can use, and that maybe this time around, as it's being introduced, that people actually will be successful and enjoy doing it this way, whereas before I think it was a big struggle.
Well, thanks for being a leader in this venture into radial artery. Thank you very much.
My pleasure. Thank you.